Great. Our next speaker is Dr. William Shrank. Dr. Shrank is an assistant professor at Harvard Medical School and part of the core teaching faculty at the Brigham and Women's Hospital. He's a renowned expert on medication adherence, and his paper focuses on the use of health IT to promote adherence for patients with both cardiovascular disease and diabetes.
Thank you, Sachin. Yeah, so our goal was to better understand what's known about the role of HIT in interventions to improve the way patients adhere to chronic medication therapy. I think it should come as no surprise to anybody in this audience that non-adherence to chronic medication therapy is a massive public health problem, leading to enormous amounts of morbidity, mortality, and costs in the U.S. that are estimated upwards to $300 billion a year. So somewhere in the order of $1 trillion during our president's current term. And efforts to reduce the waste and improve the way patients take their medications is a central health policy, health reform theme. There's a lot of reasons to believe that HIT interventions could play a very substantial role in the way patients take their medications, that there's an opportunity to both communicate directly with patients, with doctors, to provide reminders, to provide education, to encourage better communication between doctors and patients, and even to better engage or motivate or reward patients by feeding back real-time data about the medications that are being purchased and or used. So we sought to understand what's known, what's been published in the literature, so that we could start to work towards building best practices and understanding what ought to be implemented and how should we inform the building of future HIV interventions to improve medication adherence. We conducted a systematic review of the literature. We included articles focused that included a prospective randomized controlled trial to improve adherence in the areas of cardiovascular drugs and or diabetes drugs, which represent the greatest source of morbidity and mortality in the U.S. So we identified that subset of articles that could tell us about the role of HIT in improving adherence. In general, it was a disappointing search in that we found a total of only 13 articles, and of those 13 articles, many were quite small and not of the greatest quality. One reassuring piece was that there were a handful of articles that focused on patient reminders. They were consistently effective, consistently had relatively good effect sizes. They are very inexpensive, highly scalable, and could easily be implemented broadly from HIT platforms. However, in the areas of using HIT systems to improve patient education, to feed back information to doctors, we found very little evidence of success, and we found very little study of the role of HIT in really engaging, motivating, encouraging patients to better adhere to their medications. So the take-home messages are that this potentially really important source of interventions to encourage patients to take their medications has been relatively poorly studied, and we're a long way to go before we can build best practices and really take a stand on how to best optimize the use of HIT to encourage medication adherence. But we should be reassured that very simple, scalable, inexpensive interventions simply just to remind patients about when to take their medications and when to refill their medications seems to be effective. And there's a particular gaping hole in the need to better understand that next step of how HIT interventions can better engage patients, motivate patients, reward patients, and address more of the rationale for non-adherence than just forgetfulness.
Dr. Shrank, there's been some noise from the medication adherence research community that medication adherence should potentially be incorporated into future meaningful use criteria. What are your thoughts about that?
I would bet that I'd be one of those people in that that's clamoring. So I think the challenge to date is that our evidence base is weak, and we're certainly not going to advocate for meaningful use requiring something that's not well proven. That said, I think we all recognize that there is a real opportunity here, and the opportunity today is to do better research and to figure out what works. And if we are able to figure out what works, and we are able to put together a better understanding of not only what best practices are, but what the return on investment might be, and what our expectations are in terms of the benefit, I think it's a very reasonable consideration, thinking down the road for maybe stage 3, to try to implement some of this stuff.
Terrific. Are there any questions for Dr. Shrank? Dr. Nair?
Good morning. My name is Geetha Nair. I'm the Principal Medical Officer at Vangent. And I was just curious if in your review you had found anything regarding different cultural populations with regards to using technology for medication adherence.
We did not. It's a great question. So if you look broadly at reasons and the rationale for why patients don't adhere, there are many. And that's one of the reasons that simple reminders will only deal with a very small part of the problem, and cultural reasons, cultural considerations about medication are an important barrier for subpopulations of patients. In this literature review that just looked at HIT interventions, there were none that thoughtfully addressed or tried to overcome these cultural barriers. There was one, a paper by John Pate at University of Michigan, that focused on a low health literacy Spanish-speaking population using IVR, IVR phone calls. That was moderately effective, but I think essentially at this point that there's so little work that's been done in this area that it's hard to speak to that.
Sounds like an opportunity.
Yeah, absolutely.
Hi, my name is Julianne Brown. I'm a health policy fellow at the Center for the Study of the Presidency and the Congress, and also a second-year MPH student in health policy at George Washington University. My question is surrounding mental and behavioral health and adherence to those type of prescription drugs, and as that is becoming more of an issue in collaborative efforts integrating mental and behavioral health in primary health care. Did you come across any research or any outlook on the difficulties facing chronic care adherence versus behavioral and mental health care prescription adherence?
So you're asking, this is a very good question, but not one that we addressed at all. So in our inclusion and exclusion criteria, we really narrowed down to a smaller focus, and we were looking just at cardiovascular drugs and diabetes drugs. So this is another area that's ripe for further evaluation, but it's not one that we can speak to from this paper in particular.